Okay, this is chapter 58. Excuse me. We're going to cover headache, multiple sclerosis, and Parkinson's. We'll start with headaches. There's different types of headaches, as you can see: sinus, cluster, tension, and migraine. Others have organic headaches caused by intracranial or extracranial diseases, but probably the most common type of pain experienced by humans is headache. It can be venous, like sinuses, in the dura, cranial blood vessels. Even that's a lot of times with the brain injury. It can involve the facial nerve, cervical nerves, the shoulders. Because these nerves have both motor and sensory function, increased pain intensity and symptoms can occur with a person moving. So the majority of people have functional headaches. Migraines are very common. You can see that associated with pain, nausea, and visual changes. They're typical. Tension is pain in the band squeezing the head. A lot of times you'll feel this in the shoulders too, in the back of the neck. Cluster is usually pain around the eye. And again, it usually wakes them up in the middle of the night. And then, of course, most of us West Texans have real true sinus headaches, pain behind the forehead and the cheekbones. So tension type headaches, also called stress headaches. It's the most common type of headache. These headaches are characterized by bilateral location and pressing or tightening quality. That's how the pain feels. They're usually mild to moderate intensity, but can last for a few minutes and hours or up to days, depending on the situation. They are neurologically similar to migraines, but they often evolve from episodic, like having them ever so often, to chronic. And again, they're usually with increased stress or tension. Headache, the causes usually hunger, lack of sleep, again, stress, overexertion, depression, anxiety, even dehydration can be associated with these. Although the cause of tension type headaches not really fully understood, it's believed to have a neurobiological basis, kind of similar to migraines, just like we said. Again, the pain is usually bilateral, frontal, or occipital, described as constant dull pressure or a band around the head. And then, of course, neck pain and cervical neck muscles may be involved. It can have photophobia or phonophobia, where sounds and lights can cause it to be worse. But again, a lot of times you'll see that with the migraines. Migraine headaches, that's a reoccurring headache, usually characterized by a unilateral throbbing. Again, light, sound, and smell sensitivity occurs. Other environmental factors may be symptoms or triggers for the migraine. Again, they're usually associated with unilateral throbbing pain, nausea, vomiting, sensitivity to light and sound, and they're definitely more common in women. It affects about 18% of females and 6% of males in the U.S. Normal occurrence onset is usually 20 to 30 years. Risk factors for migraines is family history. If your family has a history, or a parent or a grandparent, that it can run in your family. Low level of education, low socioeconomic status, high workload, frequent tension type headaches. So if you have a lot of tension type headaches, that can be a risk factor for you developing migraines. They sometimes come with an aura, A-U-R-A, an aura, and some come without. But an aura is like a feeling or a sensation that you know that it's coming on. It's kind of like what we call an aura before a seizure. The patient realizes it's fixing to develop, whether it be little curvy lines or lights, or increase, nausea, vomiting, something that is triggering them or making them realize it's fixing to come on. Most migraines without aura are formerly called common migraine, and it is the most common type. But if you have auras with it, it's a classic migraine. Again, genetic factors have a role. So, cluster headaches, they're the most severe primary headache. Generally occur at the same time of the day or night. Onsets between 20 and 45 years of age, but men usually affected 3 more times than women. They're the most severe form of a primary headache, and they can occur in clusters, generally at the same time of day or night. Again, they usually have unilateral pain, and it's usually right behind the orbital socket, or supraorbital and temporal regions. That's usually the site of pain. A lot of times triggers can include alcohol, odors, weather changes, barometric changes, but really the true cause of a cluster headache is unknown. The unilateral pain may occur with activation of neurons in the ophthalmic branch of the trigeminal nerve. So cluster headaches also involve the hypothalamus with irregularities in melatonin and cortisol. So it definitely wakes them up in the middle of the night a lot of times. Again, they occur at the same time of day or night, so it doesn't always have to wake them up. But the first line of treatment for this is to use oxygen therapy. So we use, that's the treatment for a cluster, and it usually will resolve it. So pain location, common types of headache. Again, most frequent site for tension headache is like a band around the frontal lobe all the way back to the occipital. Migraine, again, unilateral here on one side around the temporal lobe, and then again the cluster is around the orbit. Again, other headache types you can see associated with subarachnoid hemorrhage, which is a brain bleed in the subarachnoid space. Brain tumors can cause headaches. You can see there's other kind of problems there. Drug therapy. Usually mild to moderate headaches we treat with aspirin, acetaminophen, or an NSAID. In combination, sometimes alone, or sometimes they'll combine it with a sedative or some kind of muscle relaxant or a tranquilizer. Preventative, sometimes we will, the healthcare providers will prescribe tricyclic antidepressants and anti-seizure medications, which can help alleviate the problem. For migraines, the treatment, it's kind of determined, the goals to terminate and decrease the symptoms. Imitrex is another medication that you'll see given for mild to moderate migraines. A lot of time coffee or caffeine can also help with caffeine containing with analgesics like Excedrin migraine. If you notice, Excedrin migraine has acetaminophen and caffeine and something else in it, so it helps with that. Also, for migraines, Botox is another treatment modality that they have found that is helpful. Selective serotonin reuptake inhibitors, that's what SSRI stands for, which is an antidepressant, and sometimes like anti-seizure, like phenytoin, or there's another one. Anyway, it can help as well. It's not that you have to know the medications per se, but just knowing what type of headache is which and what the treatment modality could be. Again, 100% oxygen on the cluster headaches at 6 to 8 liters for about 10 minutes. And some may have to have continuous access to O2, so depending on the time of day that it occurs. Also, verapamil can be a preventative, which is a antihypertensive. NSAIDs and acetaminophen and aspirin are going to be your most common. Start with prescriptions, and then we can evaluate from there to see if it's effective. I would definitely, on assessing patients the type of headaches, he would ask health history about seizures, cancer, any kind of stroke, mental illness, what kind of stress they're having in their life. For females, their menstruation, does it occur with that? What brings it on? Is there triggers? And just, of course, a good pain assessment, the location, the type of pain, onset, frequency, duration, time of day, and then relation to outside events, or does anything make it worse or better? Along with the headache, they may have some anxiety, apprehension, irritability, sweating, even flushing, conjunctivitis. But again, your diagnosis there is definitely acute pain related to a headache, and we would want to do our interventions to reduce the headache medication-wise. Put them in a low, dark lit room with the lights off. Sounds, again, noxious odors, you would want to avoid that with them. Teaching preventative treatment. Dietary, sometimes food can trigger migraines. A lot of times they'll say caffeine, or like chocolate or alcohol can trigger migraine, so we can do patient teaching to avoid those too. Multiple sclerosis. Okay, multiple sclerosis is chronic progressive degenerative disorder of the central nervous system. It can affect people at any age, but the symptoms usually start appearing around ages 30 to 35. It's definitely more progressive when diagnosed at an older age, and it affects women 2 to 3 times more often. It is characterized by segmental demyelinization. That's a key term, demyelinization of the nerve fibers of the brain and spinal cord. Okay, so it takes the myelin off those nerve fibers, which would affect the neurotransmission of messages getting to our peripheral, our muscles, and our breathing and our extremities. There's about 400,000 Americans affected. It's definitely more prevalent in temperature climates, temperate climates. Some environmentals before puberty may predispose them to MS. Also a family history. Really the cause, I think, is still unknown, but it's unlikely to be related to a single cause. Possible factors they have included are infection, smoking, physical injury, even emotional stress, pregnancy, or just a general poor state of health. Also, there is the genetic component if they have a family history of MS. 3 pathological processes characterize MS. They deal with chronic inflammation, again, demyelinization of the spinal cord, and gliosis, which is scarring in the central nervous system. Primary neuropathic condition, it is autoimmune process, and it's, again, activate the T cells. This is talking about autoimmunity that migrate to the central nervous system and that disrupts the blood-brain barrier. Initially, the attacks cause damage to the myelin sheaths of the neurons in the brain and spinal cord. The nerve fiber is not affected, it's just the sheath that covers them, the myelin. Clinical manifestations, the onset is insidious or gradual, meaning it comes on slowly. Sometimes they're vague in the beginning or intermittent over months to years. And really, they're just so generalized, they're not really enough to seek medical attention. Chronic and progressive, and it causes deterioration in a lot of patients. Remissions and exacerbations in others. Overall, the trend is progressive again, and it affects the central nervous system. You're going to sometimes see around the first symptom that they complain of or present would be blurred vision or double vision, maybe even a red or green distortion or color, even blindness in one eye. Other common manifestations are the motor problems. Again, you're going to have those neurons, that spinal cord and brain is being demyelinated. The sheath that protects those nerves is being disrupted. So again, motor and sensory problems, cerebellar problems. Remember, the cerebellar helps with balance. So we could have some falls, balance problems, or even emotional. They become weak. They have paralysis of the limbs and the trunk. They have muscle spasticity. They have a scanning speech. It's kind of like a slowed scanning speech, that kind of like that. Numbness and tingling, pain, even decreased hearing, vertigo, which is dizziness and tinnitus, ringing in the ears, chronic neuropathic pain. Again, some very common symptoms. Cerebellar manifestations, again, ataxia is where loss of motor and speech, nystagmus, dysarthria, fatigue, dysphagia, difficulty swallowing, even flaccid or a spastic bladder can happen, so they start having some bowel and bladder incontinence or impairment. Even decreased libido or erectile dysfunction, painful intercourse, decreased lubrication. Cognitively, again, short-term memory attention is affected. They have trouble processing information. They do have visual perception issues, again, that can cause blindness, spots, or double vision. And again, it's emotional. I moved the slide and I can't go back. Emotional, like anger, depression, anxiety. Definitely no definitive diagnostic test for MS, but it is based primarily on history, clinical manifestations, and the result of a few diagnostic tests. They can do an MRI of the brain and spinal cord, and that'll show the presence of some plaques, inflammation, and atrophy, and tissue breakdown and destruction. They can do a cerebral spinal fluid analysis, and that will show the presence of increased immunoglobulin G. And then, of course, they can look at nerve conduction too, from the eye to the ear and the brain. Interprofessional care and drug therapy. Currently, there is no cure for MS, but the interprofessional care is aimed at treating the disease and providing symptom relief. Therapy is usually tailored towards manifestations or signs and symptoms to control those experienced by each patient. Early intervention is the key and the most effective for quality of life. So you're going to see them prescribed drugs like immunosuppressants, immunomodulators, and drugs called adrenocorticotropic hormones. Like interferon B would be something we would give to help modify the disease progression and prevent relapse. Because these are immunomodulators and they do have some side effects that go along with it. You don't have to know the drugs, it's just kind of knowing what class of drugs would be used to treat it, specifically named of drugs. Again, more treatment of relapsing forms. There's just a list there. Again, I'm not asking you anything about the drugs, just knowing the class would be what kind of medication is associated with administration for someone with an MS exacerbation. Corticosteroids, methylprednisolone or prednisone can help with treating acute exacerbation. Again, decreasing inflammation and immune response, reduces edema at the site of the demyelinization. Muscle relaxants, because of the spasticity of the muscles, can help. Even antidepressants, tricyclic, anti-seizure drugs, there's all different kinds of classes that can be used to treat it. And a lot of times it's very individualized. They have to find the right combination that works for each patient. There are some surgeries that can happen. Other interventions may be required in treatment of spasticity. They can do an intrathecal baclofen pump, dorsal column electrical stimulation. Again, these are surgical implantations. Exercise can help relieve spasticity and improve coordination. Again, water. There's a picture of a guy in the water. Water is always, water aerobics or water exercises are good for this type of patient as well. So health history, you would ask about any viral infections or vaccinations. They do link, they've done studies on a lot of different bacterial and viral infections that may contribute to the cause of MS, even vaccinations. Again, do you live in cold or temperate climates? What kind of physical, emotional stress are you under? What medications are you taking? Again, it could be medication induced. We don't really know, but it could play a role. Muscle weakness, fatigue, blurred vision, lost vision, again, anger, depression, mood changes. You know, just listen to them, allow them to adjust, talk, remain neutral about how you want to allow your patient, if they're angry or depressed or even euphoric, you want to be able to have that therapeutic relationship and response with them, help them grieve. Objective data, you probably might see apathy or inattentiveness. If it affects their mobility, you could assess pressure ulcers because of the lack, they're unable to move, so the pressure builds up, causing breakdown of skin. Again, the scanning speech, tremors, nystagmus, where you see the eyes almost go back and forth. They like twitch, not twitching, but the eyes are shaking almost. Can't explain it right now, but ataxia, spasticity, hyperreflexia, decreased hearing, muscular weakness, paralysis, even foot dragging, and dysarthria. So the plan is to, of course, maximize the neuromuscular function, help them maintain ADLs as long as possible, and manage fatigue. Well, of course, teaching and adjusting to the illness would be a key in this treatment modality. Help them identify triggers, ways to avoid them, reassure the patient about the diagnostic phase, assist the patient in dealing with anxiety and grief. Again, they're dealing with a diagnosis that is incurable, so the progression is going to lead to them dealing with some end-of-life choices or even debilitating choices. We want to teach them good balance of exercise and rest as long as they can, minimize their caffeine intake, nutritious, well-balanced meals, increase their fiber if they become constipated, which can be a side effect. And at the end, even self-catheterizations, once they lose that bladder control or the ability to urinate due to the muscle flaccidity, then self-catheterization may be necessary. This is a question about interferon B, beta-seron, has been prescribed for a patient who has been diagnosing with relapsing remitting multiple sclerosis. Which statement, if made by the patient, indicates that additional teaching is needed? I must rotate injection sites with each dose. I should report depression or suicide. I will reduce my sodium intake to prevent edema, or it's important to avoid direct sunlight and use sunscreen. The answer is C. I will reduce my sodium intake and prevent edema. Okay, Parkinson's disease. This is characterized by also a chronic progressive neurodegenerative disorder. But what you're going to see is what we call bradykinesia, rigidity, tremors, and gait disturbances. Okay, incident increases with age, is definitely more common in men. Although it's not considered a hereditary condition, genetic links can be should be evaluated. If they usually it says about 15% of patients with Parkinson's disease have a positive family history in their disease. It is associated with the lack of dopamine. Okay, so dopamine is a neurotransmitter in the brain, and the generation of dopamine producing neurons causes us to have problems with extrapyramidal, I never can say that, EPS, motor system. So that's where the tremors start having an occurrence. So the chemicals in the brain, we don't have enough dopamine to control. The Lewy bodies, you're going to see a term called Lewy bodies, usual clumps in the proteins in the brain, that's what we call them, found in the brain in the patients with Parkinson's disease. Again, there's an unknown cause, but it usually indicates abnormal brain functioning, in which we call it Lewy body dementia. So it can lead to forms of dementia. Again, the onset is usually gradual and insidious with ongoing progression. You can remember the symptoms by tremor, rigidity, akinesia, and postural instability. So you're going to see them with the slumped over posture and the shuffling gait, tremors, muscle rigidity, very common. Beginning steps, again, it starts with mild tremors, a slight limp, or even a decrease in arm swing. It goes to shuffling gait with their arms flexed and loss of postural reflexes, so they can't hold themselves up, so they stoop over. 90% experience hypokinetic dysarthria, which was a speech abnormality. Again, tremors are usually the first sign initially. And then they're definitely more prominent at rest. So if you sat down and they were resting, you could see them tremoring. They have a pen rolling hand tremor. Again, the diaphragm, tongue, lips may be involved. Lip smacking, tongue rolling, pen rolling hand tremors. Essential tremor is not associated with Parkinson's disease, but it occurs during voluntary movement. It has more rapid frequency. Rigidity, that is increased resistance to passive motion when the limbs are moved through range of motion. They have a jerky quality of movement and rigidity, sustained muscle contraction. Again, this is all from lack of dopamine. They will feel complaints of soreness because their muscles are so rigid and tight and tense, because they're going to feel tired and achy, like they've been working out. They can also have pain in the head, upper body, spine, and legs. Again, blank facial expression, a forward tilt to the posture, slow, monotonous, slurred speech, tremors, short, shuffling gait. When we say bradykinesia, that's that slowing of movement. Non-motor symptoms, anxiety, depression, apathy, fatigue, pain, even urinary retention and constipation. And of course, you would definitely start seeing memory changes long term. Again, sleep problems are common. They have difficulty staying asleep, restless. They get drowsy during the day because they have had, again, their muscles are so rigid and tight that they're exhausted. Potentially dangerous motor activity because they can have nightmares in the REM sleep. Complications, of course, as the disease progresses, you're going to see motor symptom problems where they get to the ability where they're immobile, they can't walk, they can't keep a steady gait, weakness. They're going to have neurological problems and even neuropsychological problems. Dementia is associated with it because of those Lewy bodies deposits in the brain. And of course, dementia increases their mortality. Dysphagia, they may have trouble swallowing, so that can result in weight loss, malnutrition, or even risk for aspiration. General debilitation can also lead to pneumonia, due to inactivity and decreased mobility, UTIs, and skin breakdown. Orthostatic hypotension and that would increase their risk for falls. Again, no really specific test to diagnose it. It's based on history and physical, but they do diagnose. There are pictures they can do on MRI here, I believe, of the brain that shows a normal brain and Parkinson's. The confirmation is positive response to an anti-Parkinson drug. There is no cure for Parkinson's either. We just do interprofessional care really aimed at symptom management again, and in correcting imbalances of the neurotransmitter. We would prescribe anti-Parkinson drugs, and we're going to talk about that. Levodopa with carbidopa, a real common drug. It's called Sinemet. It's the primary treatment. It can cross the blood-brain barrier and convert dopamine in the basal ganglia. Carbidopa inhibits an enzyme that breaks down levodopa before it reaches the brain. So that's how that works. Effectiveness could wear off after a few years, so sometimes they have to use additional medications with it to help control the involuntary movements. So antiviral agents, amantadine, it increases dopamine release, and that blocks the reuptake. There's medications like anticholinergics that decrease activity of anticholinergic esterase. MAO-B inhibitors, these are all, again, classes of medications. Prolong the half-life of levodopa. There's medication called diphenhydramine, which is Benadryl, and a lot of times you'll see that in combination with carbidopa medications to help prevent the muscle tremors. There is surgical therapy. Again, they're going to start with least invasive. Again, there is no cure, so they're going to start with medications for treatment. Surgical, if they're unresponsive to drug therapy, they can have a stimulator embedded into the brain. It's called deep brain stimulation, where they go in and try to ablate the area that's causing the interruption in the neurotransmitter. Again, ablation therapy, they locate, target, and destroy the area of the brain affected by it, destroys tissue that produces abnormal or chemical electrical responses. Nutritional therapy can have a role. Malnutrition and constipation can be serious consequences, so a lot of times we want to maintain nutrition with protein supplements and oral feedings to help maintain weight. If they have dysphagia, and they need help eating, so we can do a pureed diet, thickened liquids necessary for them. They should eat like small meals, because it's less exhausting than eating a bunch of large meals. And then, you want to provide ample time when you're feeding them, because they will get frustrated sometimes. Again, health history based on trauma, any kind of cerebrovascular disorders, exposure to metals or CO2, encephalitis, medications. There's a lot of things to assess. And then what kind of symptoms are we having? Do you have complaints of fatigue or excess salivation? Because a lot of times they'll drool because of the inability to control the motor movements of the mouth. Again, difficulty swallowing, weight loss, constipation, incontinence, initiating movements, difficulty with that, history of falls. So those are all good questions on the assessment that you would want to ask. Again, a lot of times they look like they have a blank face, like they don't blink very much. Ankle edema, postural hypotension, tremors are going to be your, again, your initial and most indicative. It definitely gets worse when they're upset or anxious. Again, pin rolling. They just pin roll of the hands, poor coordination. Again, falls, contractures, a stooped gait. You saw the picture of that guy shuffling and stooped posture, shuffling gait and stooped posture. Again, the plan is just to maximize neurological function, maintain ADLs as long as possible, and then of course their psychosocial well-being. It is degenerative and it will progress. Medications can hasten that progression, so we want to try to get medications on board quickly so that we can help them slow the progression. Again, here's your evaluation on what your outcomes for the patient, meeting nutritional needs, performing ADLs up until they can to prevent joint contractures, using assisted devices to help with ambulation and mobility to prevent falls. Again, using methods of communication if it comes to that, and experiencing passage of fluids and solids from the mouth to stomach. So even if they need constipation medications or even changing of diet because of dysphagia, we would want to do that.